So our next speaker is Dr. Magdalena Cerda. She's professor and director at the Center for Opioid Epidemiology and Policy at the Department of Population Health at NYU Langone Health. Her work integrates approaches from social and psychiatric epidemiology to examine how social context and drug and health policy shape drug use and urban violence. And her current funded research focuses on state and community level policy and social drivers of opioid-related harms, including the work on the impact of municipal harm reduction laws on overdose and the evaluation of the first sanctioned overdose prevention centers in the United States. And we're also welcoming her back because she got her doctorate in it was under a different name at the time, but what is now social behavioral sciences. So welcome back. We found out this is her first time back to Harvard. So give her
Thanks so much for having me. When I was walking through the cafeteria gave me slight PTSD, thinking back to, the written exam, preparing for the written exam, but great memories of HSPH. So today I'm going to talk about a different topic, which is opioid overdoses and how can we evaluate the effect of local harm reduction laws. And what I'm going to try to convince you of, maybe not that exciting a topic, is why it's really hard to evaluate the effect of these laws. So this is work that we're doing as a team with investigators across institutions, and it's funded by an R01 that is co-led by Dr. Charles DiMaggio and myself. So what we're trying to address here is the opioid overdose crisis, which has been really driven by a very lethal drug product, primarily fentanyl and other illegally manufactured synthetics, and which has claimed more than 1.1 million lives since the year 2000. Now, because this is an epidemic that is really driven by a highly lethal drug supply, harm reduction services, which meet people where they are and provide them the tools they need to be able to protect themselves from the potentially adverse effects of drug use, are particularly vital tools that we need to focus on. And when we're talking about harm reduction services, it can include many things. For example, syringe service programs that distribute syringes, smoking equipment, and drug checking equipment. It can mean fentanyl test strips so people can test their drugs and make an informed decision about how and where to use them. Overdose prevention centers where people can use drugs safely under supervision and receive help if they overdose. And community-based overdose prevention programs that distribute naloxone, which is a medication used to reverse overdoses. Now, states and municipalities have enacted a number of laws in response to the overdose crisis to either facilitate or constrain access and availability of these vital harm reduction services. And so when we think about these laws, they can include, for example, laws that regulate the possession and distribution of drug paraphernalia like syringes, smoking equipment, and fentanyl test strips. They can involve laws that regulate the operation of syringe service programs and laws that declare drug paraphernalia-related activities a nuisance that can be evaded by forced removal or eviction of somebody from a rental property. So if we are going to inform an evidence-based approach to addressing the overdose crisis, I think we have a role to play as scientists in providing evidence to bear on what works and what doesn't work. And so a lot of my work focuses on evaluating the effect that harm reduction laws have on overdose. And so the question that we want to ask is, are these laws effective? This is a really hard question because there are a whole host of methodological issues that make it a hard question to answer. Now, there's been some work already, a substantial amount of work evaluating the impact of harm reduction laws on overdose and related harms. However, most of that work has really focused on the impact of state-level harm reduction laws. I would argue that we need to go beyond the state and dig down to the local level. And why is that? For two reasons. First of all, most variation in harm reduction laws actually occurs at the local level. And second, the impact of state laws often depends on what laws are in place at a local level. Now, if evaluating state laws is hard, what I'm hoping you'll leave this talk understanding is that evaluating local laws is even harder. unfortunately. So there are a number of challenges associated with evaluating local laws, and so you can see a list of some of them here. I only have 14 minutes, less by now, so I'm just going to focus on the first three. And to illustrate my points, I'm going to use a case study, and this is our study that I mentioned at the beginning, where what we're trying to figure out is what impact do municipal laws have on the access and availability of harm reduction services and on overdose and related harms. Our study focuses on evaluating the impact of three types of laws: those that regulate the possession and distribution of drug paraphernalia and naloxone, those that regulate the operation of syringe service programs, and those that declare the ability to declare rental properties and nuisance. The study population that we are focusing on is 482 municipalities across the 50 states of the United States. Okay, so I said I was going to talk about three challenges, among others, in evaluating the effect of local harm reduction laws. So the first challenge is you need to actually have data to figure out what the laws are, right? In order to evaluate them, you need to know what the laws are. Actually, it turns out that getting that data is really hard. So in our case, we need to, there's no data. So there's some data on state harm reduction laws. There's no data on local laws. And so when you think about states, measuring those laws is hard, but you're talking about 50 units. We're talking about municipalities. In our case, we're talking about almost 500 units. So that issue of data collection is really blown up and much harder. So how are we doing that? So we're collecting data for the first time on those three types of laws that I mentioned at the beginning. In order to do that, we're having three people, three research assistants, manually extract and code the three types of laws. So far we've done one wave. It's taken us 2 years, and three people to extract and code the three laws, the three types of laws. Also, what it turns out is that as you go along and you're collecting these data, you realize, oh, I should have asked this other question about the laws, but now you can't change your mind because that would mean you'd have to go back to, jurisdiction number one. So it's really hard, it's really time consuming, it's really expensive. But we need these data if we want to figure out what works. So what's the solution? So what we're exploring is a potential solution to reliably and feasibly update laws over time, which is using large language models to automatically collect and code these laws. This is an emerging project that we really just started working on in the next year, so let's stay tuned. But what we're trying to do is using retrieval augmented generation, or RAG, where we first start with a collection of municipal laws and research queries, like the example that you see here. Then we use an embedding model to index the source documents of the laws and retrieve potentially relevant sections to give the context for the large language model. And then we use a large language model to evaluate the segments for relevance. So we can say this is relevant, this is not relevant, and then to generate a coded response about, answering the questions that we have. And then we can actually have the model provide us with citations, retrieve segments, and a rationale to be able to validate the model. So if this works, I think this could be really life-changing, not only for local harm reduction laws, for any kind of law, because we really need to get data on laws to figure out what works. So there's some challenges and potential benefits with this approach. First is just access. It turns out that particularly for municipal laws, a lot of them you have to pay. There's a paywall behind the databases that host the laws. Second is consistency. It also turns out that different municipalities don't have the same uniform organizational structure for legal codes. And so that increases the complexity of the code used in the large language model. And finally, quality. So we need to know whether the model works, right? Is it giving us the right answers? And so the quality of our validation effort is really going to depend on how much human-coded data there is to compare to. But there are some potential benefits. In our case, we actually have this unique situation where we have all of the laws already coded by humans. So we can use that as the gold standard to validate the automated coding against. Also, another potential benefit is that this large language model may actually be able to identify relevant code that a simple keyword search by research assistants would have missed. And finally, it really reduces cost, it reduces time, and it also gives us much more flexibility to add new questions to the query. So stay tuned for what we find with the use of large language models to automatically code data. The second issue that comes up when evaluating local harm reduction laws is that how to characterize the local laws. And so what's the issue here? The issue here is that municipal laws are actually embedded within state laws. And that the status of municipal laws directly depends on how much control states actually give to municipalities to enact their own laws. So let me give you an example to illustrate this. This is a map showing you the state level control over local syringe service program laws. You have some states in the red that provide no local jurisdictional control for syringe service program laws. So localities cannot make their own laws. It's all state driven. Then you have other localities like those in the green and in the blue that actually the states do provide local jurisdictional control to be able to enact and terminate SSPs. And then finally, you have other states in the gray where there's no law around syringe service programs. So, for example, you might want to evaluate the effect that enacting a local municipal law around the regulation of syringe service program would have. And so imagine you would do that in Louisiana, where the state actually gives power to localities to enact their own laws. And so you would say, okay, I'm going to look at Louisiana. And so then you might think, okay, I'm going to compare localities in Louisiana to localities in Montana. If you didn't know anything about the state, you might think that made sense. But actually, Montana is not a good control for the localities in Louisiana because in Montana, there's no local jurisdictional control of syringe service programs. So the locality has no probability of actually being able to change their local law. So using that as a control would be a violation of the positivity assumption. So that means that it's really complicated to think about how to characterize the local law. And in order to do that and to be able to choose the actual appropriate comparison group, you need to think about what's the state law, what's the state control over the local law, and what's the local law. So we've been trying to puzzle how to do this. The solution that we've found, which is admittedly very crude and imperfect, and I would love input on better ways to do this, is basically to create buckets of state and local law combinations. So this is just an example looking at laws regulating syringe distribution. And so what you can see here is we've grouped all of our study municipalities by the state law in the top, the municipal ordinance and the municipal ordinance in the middle. And so we found 9 buckets of state and local law combinations. And so what we're going to do is actually compare jurisdictions across all of these buckets so that we can actually consider the state law, the state control over the local law, and the local law at the same time. So the challenge here is really that when we're looking at evaluating local laws, we need a measure that respects the complex state and local legal environment while satisfying assumptions of consistency and positivity. And in order to do that, we really need to consider both the state and local laws, both to be able to better define the exposure, but also to select the right comparison group. And so we think that, the solution we've come up with is creating these state and local law buckets where we can jointly capture the state law, the control over the local law, and the local law. And so with these buckets, we can figure out what's the appropriate comparison group given state limitations and allowances. Okay, the third and final challenge that I'm going to be talking about is confounding. So we can't do experiments with local laws because they're not enacted in a way, they're enacted for different reasons. There are 2 issues here that we need to address. These are issues that we need to address when we're evaluating state laws, but they're even worse with local laws. The first is co-occurring laws. So it turns out that states and municipalities are going to adopt multiple laws to address an emerging problem like overdoses. And so we need to account for those co-occurring laws to actually be able to estimate a valid effect. But the problem is that when we're controlling for those other co-occurring laws, we also run the risk of inducing positivity violations that can substantially inflate the variance of effect estimates. The second issue is time-dependent confounding. Huge issue when we're looking at harm reduction laws. Why? Because localities and states are often enacting these laws in order to respond to the overdose crisis, right? So there is this substantial confounding by prior levels of the outcome that we need to disentangle. So what are our solutions to this? The first thing, in terms of addressing the co-occurring laws issue, what we're doing is we're using the approach recommended by Ellie Mathey and others, which is basically using a correlation heat map, where we actually map out the correlation that our law of interest has with other potentially co-occurring laws. An example here is laws authorizing syringe service programs. And then we identify whether there are highly correlated laws that may induce a problem of positivity violation. And then we're thinking about different ways to redefine the exposure in order to avoid those positivity violations. One is we can redefine the exposure to look at law clusters instead of a single law. A second is what Kara Rudolph has proposed as the modified treatment policy estimate, where we are basically comparing the counterfactual outcome had the municipality delayed the enactment of the law by X amount versus what was observed. Now, these are approaches that have been tried with state laws. But remember what I told you about how we need to measure these local laws in these very complicated buckets? So now, imagine this issue blown up much more when we're looking at the local level, because we need to think about correlated laws at the state level, at the local level, and the interaction between the two. So how are we going to do that? That's a real challenge that we're trying to grapple with now. The second issue is time-dependent confounding. This is another issue that we've really been trying to puzzle through, particularly because the standard difference in difference models that are used for policy evaluations do not allow us to account for treatment confounder feedback. Now, there is a potential for using longitudinal G methods to account for this time-dependent confounding, particularly when we have multiple measures of the laws and the outcomes. There are specific, again, challenges when we're evaluating local laws, including low counts of the outcome because we're looking at small areas, and spatial dependencies and potential threats to interference. So here, what we're trying to do is exploring the potential for Bayesian frameworks to address these local level challenges, embedding G models within Bayesian frameworks. So stay tuned for how this all turns out. But in conclusion, state and local laws facilitate and constrain the availability of these really crucial life-saving harm reduction services. As scientists, I think we have a responsibility to figure out what laws work and what laws don't work. The traditional challenges to causal identification in policy evaluation are really blown up when we think about local laws, including how to collect the data on the laws, how to characterize the legal environment, and how to address confounding. I do think, though, I have hope, because I think that innovations in artificial intelligence, in legal epi, and in causal inference can really help us identify the causal effect of local laws. Thank you so much.